Zenagamtide targets two hormones in one molecule. In one small trial, a weekly injection produced 24.3% weight loss at 36 weeks. That result could make Zenagamtide a future rival to Wegovy and Zepbound. It combines signals that act like amylin and GLP-1. These two fullness signals may reduce hunger and help people end meals sooner. It differs from drugs that target GLP-1 alone. Wegovy contains semaglutide, which acts like GLP-1. It strengthens fullness signals and improves blood sugar control. Many people then eat less without fighting hunger all day. Amylin adds a separate meal-ending signal. It helps the brain recognize that enough food has arrived. Your pancreas releases it with insulin after eating. It also supports steadier blood sugar after meals. Zepbound contains Tirzepatide, which acts like GLP-1 and GIP. GIP helps the body release insulin after eating. Zenagamtide uses an amylin-like signal rather than GIP as its second signal. Using an amylin-like signal may change how zenagamtide reduces appetite. Zenagamtide may reduce hunger by acting like GLP-1. The amylin-like signal may help meals end earlier. Together, the two signals may suppress appetite. The first major zenagamtide injection study enrolled 125 adults with overweight or obesity. The study included Phase 1b and Phase 2, sections that examined safety, dosing, and early effects. Participants received increasing weekly doses for up to 36 weeks. Weight loss was not the study's main measurement, but it drew the most attention. The highest planned dose was 60 milligrams weekly. Estimated average weight loss was 24.3% after 36 weeks, compared with 1.1% after placebo. For a 220-pound adult, 24.3% equals roughly 53 pounds. That is why this drug attracted attention so quickly. A separate 20-milligram group lost an estimated 22% at 36 weeks. Lower dose groups lost less over shorter periods. The stronger results appeared in groups treated longer and at higher doses. Because both factors changed together, the study cannot show which mattered more. A separate Phase 1 study tested zenagamtide as a daily pill. It reported up to 13.1% weight loss after 12 weeks. That matters because a future tablet could appeal to people who dislike injections or want a simpler routine. Researchers must show whether a daily pill can match the injection's long-term weight loss without causing more side effects. If it can, many patients may prefer it. Novo Nordisk has moved both versions into Phase 3 clinical trials. These late-stage studies are needed before approval. Planned obesity studies will test several doses over about 72 or 80 weeks. Those trials will show whether similarly strong weight loss appears in larger and more varied patient groups. Participants were still losing weight at week 36 when the early injection study ended. Longer trials may show whether weight loss continues. The 24.3% result is an early signal, not proof it beats Wegovy or Zepbound. Wegovy and Zepbound were studied in different trials, with different patients and schedules. Larger, longer studies will determine how zenagamtide compares. Average weight loss can hide how differently patients respond. Some people may lose far more, while others lose little or stop early. Future reports should show how many patients reach 5%, 10%, 15%, and 20% loss, not only the average. Side effects will shape how useful the drug becomes. Nausea, vomiting, diarrhea, and reduced appetite were common in the early injection study. Most were mild or moderate. The key question is whether patients can reach effective doses without side effects, forcing them to stop treatment. The same weight loss can come from two different treatment experiences. One person may feel satisfied sooner and naturally eat less. Another may lose weight mainly because nausea makes eating difficult. The scale result may look similar, but nausea can make treatment harder to tolerate. The speed of dose increases will shape how useful zenagamtide becomes. A powerful drug helps most when patients can keep taking it. Slower increases may improve comfort, but they can delay reaching the most effective dose. The Phase 3 clinical trials should show which dosing schedule delivers strong weight loss with side effects patients can manage. The diabetes study adds another reason to watch Zenagamtide. In 262 adults with type 2 diabetes, Zenagamtide produced up to 14.6% weight loss at 36 weeks. A1C, a 3-month blood sugar average, fell by 1.7 percentage points at the highest dose. That combination matters because obesity drugs are judged by more than the scale. A drug that lowers weight and improves blood sugar could help patients with diabetes and related health problems. Larger trials will show how consistently that combined benefit appears over time and in everyday care. Beyond weight and blood sugar, late-stage trials should show how many patients can keep taking the drug. They should report dose reductions, pauses, treatment stops, serious side effects, weight regain, and results for everyone who entered the trial. An analysis of all participants shows whether the average represents the full group, not only those who finished. The type of weight lost will matter too. Rapid weight loss reduces body fat, but it can also reduce muscle mass. Trials should report muscle loss, strength, and daily function, especially when appetite becomes extremely low. That will show whether the weight loss improves health, not just the number on the scale. 36 weeks shows how quickly weight can fall, but longer studies are needed to show whether it lasts. Weight loss may slow or level off with continued treatment. Weight may return after treatment ends. Late-stage studies lasting about 80 weeks should give a more useful picture. Fair safety comparisons require longer studies with more patients. Wegovy and Zepbound have been tested in much larger studies and used by many more patients. Early Zenagamtide studies are promising, but uncommon risks are easier to detect after more patients use the drug for longer. Benefits beyond weight loss will determine Zenagamtide's value. Wegovy has evidence for reducing major heart events in certain high-risk adults. Zepbound has evidence for treating obesity-related obstructive sleep apnea, repeated breathing pauses during sleep. Larger studies can show whether Zenagamtide also improves health beyond weight loss and blood sugar. The late-stage studies will test several doses of both the weekly injection and the daily tablet. They will also examine whether treatment improves health problems linked to obesity. Together, the studies can show which doses work best, who benefits, and why some patients stop treatment. Fair comparisons need similar patients, similar treatment periods, and the same rules for using results from people who leave a study early. Direct trials could reveal where each drug performs best. Researchers should compare weight loss, side effects, stopping rates, muscle loss, blood sugar, daily function, and quality of life. Zenagamtide is not yet available by prescription. Patients still choose among approved drugs today, while researchers test whether Zenagamtide can become the next major option. For people who do not respond to current drugs, Zenagamtide could offer another approach. It combines an amylin-like signal with one that acts like GLP-1. This pairing may affect hunger, meal size, and blood sugar differently from Wegovy or Zepbound. Zenagamtide could become a major obesity drug if larger trials confirm the early results. Researchers are testing this two-hormone approach as an injection and a pill. Its place beside Wegovy and Zepbound depends on lasting results, manageable side effects, protecting muscle during weight loss, and wider health benefits. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.